Welcome back to the Radiology Advances podcast. Today, we're having a closer look at interventional oncology, specifically the planning for hepatic transarterial radioembolization. And the big question is, can we perhaps get rid of an invasive imaging step but still keep patients safe?
Absolutely. The title of the article is Contrast-Enhanced CT as a Non-Invasive Alternative for Lung Shunt Fraction Estimation in Hepatic Transarterial Radioembolization, and it was conducted by Brahim Mehadji, Talia Marks, Emily Roncalli, and colleagues from the University of California, Davis in the United States.
All right, so the current standard, the way things are usually done for planning yttrium-90 therapy, it relies on injecting something called 99M-TCMAA, which is a technetium-labeled macroaggregated albumin. And it's used to figure out the lung shunt fraction, the LSF. It's basically a safety check, isn't it? To avoid lung irradiation and radiation pneumonitis, for instance.
Exactly. It is a crucial safety step.
Let's unpack the evidence from this paper, which suggests that maybe standard contrast-enhanced CT, which is widely available, could actually be a robust alternative to this invasive standard.
Okay, so context first. Transarterial radioembolization is an important treatment option for unresectable hepatocellular carcinomas, HCC, and also for various liver metastasis. We're talking significant numbers, over 10,000 procedures just in the US each year, and the benefits are clear. Longer survival, better quality of life, sometimes even downstaging tumors so patients can get a transplant. It's a really important tool.
Definitely essential, like you said, but it has this strict safety protocol.
True. Calculating the LSF basically forces this two-step process. First, there's the mapping angiogram, injecting the labeled MAA to calculate the LSF. Weeks later, the actual treatment happens. So why are the authors questioning this? Of course, convenience is part of the discussion, but the MAA method, it has a couple of, let's say, clinical weaknesses. First, yes, it is invasive. That adds time, risk, resources. But second, and this is maybe even more important, it might not be that accurate, particularly now that transarterial radioembolization is moving forward to very selective targeting.
Ah, right. You mean because the MAA tracer, it's often injected further back more proximately in the hepatic artery? So it doesn't really reflect the flow dynamics way down in a tiny segment where the treatment's actually going?
Precisely. You might inject the MAA more proximally for an overall safety check, but that bolus injection doesn't really mimic where those tiny therapeutic microspheres end up in a very focused treatment. So if you're hitting just a small tumor segment, the MAA data might, well, significantly misrepresent the actual shunting risk in that specific area.
Okay, that makes sense. So that clinical desire to getting treatment started faster really sets the stage for this study. The underlying biology here is key, right? The LSF, the lung shunting, it's driven by the tumor itself, particularly its hypervascularity, the messy, leaky blood vessels it creates through angiogenesis.
Exactly right. This arteriovenous shunting, it isn't just random. It's a direct consequence of how some tumors grow, their vascular architecture. So the hypothesis becomes, if CECT can already map these hypervascular parts of the tumor, can we use that anatomical detail, can we leverage it to predict the functional shunting, the LSF, without needing to inject a separate nuclear tracer at all?
Okay, so how did the UC Davis team actually test this? What did the study look like? Who were the patients?
It was a retrospective single-center study looking back at 30 consecutive patients who had received yttrium-90 radioembolization and both a 4-phase CECT scan and the standard planar technetium-labeled MAA imaging done within about a month of each other. The group was made up by mostly HCC with about 80%, but also some intrahepatic cholangiocarcinomas and other entities.
Okay, how did they assess the tumor? They didn't just measure, say, the overall tumor size, did they?
While they isolated the tumor components looking at total tumor volume, the hypervascular tumor volume, and necrotic tumor volume, the hypervascular bits of the tumor are fed mainly by the hepatic artery, while the normal liver around it gets most blood from the portal vein.
What was the actual process?
They used image subtraction. They took the arterial phase images from the CECT scan and digitally subtracted the portal venous phase images.
Ah, I see. So that subtraction basically removes the signal from the normal liver tissue that enhances later via the portal vein?
Exactly. It leaves you primarily with the signal from the parts of the tumor that light up early and intensely because they're fed by the hepatic artery, the parts driving the shunt. Then, they did some post-processing to computationally exclude any parts that looked necrotic. Dead tissue obviously can't shunt blood. And finally, they took that resulting volume, the hypervascular tumor volume, and normalized it. They divided it by the total volume of the liver they planned to perfuse or treat.
Okay, and was this practical? How long did this analysis take?
They reported it took around 15 to 20 minutes per patient for the image processing.
That's quite reasonable. And that level of detail focusing on the hypervascular component seems critical, especially when you compare it to simpler ideas like just measuring the tumor's total size.
Absolutely critical because just measuring the bulk tumor volume, that didn't work well at all. When they looked at simple volume, whether from radiology reports or just outlining the tumor on one phase, the correlation with the actual LSF was poor. R squared values were only around 0.34 to 0.38.
So basically, no meaningful relationship there.
Right. It tells us pretty clearly that just how big the tumor is doesn't really predict the shunting risk. It's the quality of the tumor tissue, its vascular architecture, how hypervascular it genuinely is. That seems to be what matters.
Okay, so the method is sophisticated. It targets the right biology and it's practical. The big question then, did it actually correlate with the gold standard LSF measurement?
Well, this is where it gets really interesting. When you try to correlate a physiological measure, like the MAA-LSF with an anatomical measure from CT, you usually expect some variability, some scatter in the data. But when these researchers plotted their CECT metric, that hypervascular tumor to perfused volume ratio, against the LSF measured by MAA, the correlation was exceptional.
Okay, give us the numbers. What did the linear regression show?
Let me take a step back. For the hypervascular tumor volume alone, the R squared value was 0.71. After normalization to the perfused liver volume, it further increased to 0.95, and the p-value was less than 0.001, highly statistically significant.
Wow, 0.95. That's incredibly high. For listeners, an R squared of 0.95 means that 95% of the variations seen in the lung shunt fraction could be predicted just by this CSET measurement of the tumor's vascular structure. Okay, a strong correlation is one thing. How accurate were the actual LSF predictions from CECT? Was it precise?
Very precise. They looked at the root mean square error. That tells you the typical difference between the CECT prediction and the actual MAA measurement, and the RMSE was only 3%. That's quite small in the context of LSF values.
Only 3% difference on average.
Yes. And they also did a bland Altman analysis, which is a standard way to check agreement between two methods that showed really strong agreement too, with a tiny mean bias of just negative 0.701%, essentially no systematic error. The CECT method wasn't consistently predicting higher or lower than the MAA.
Okay, and the paper included some case examples, didn't they? To illustrate how this works in practice.
They showed two patients who had tumors of pretty similar overall size. One was 8.5 centimeters, the other 9.5 centimeters. So based on size alone, you might expect similar risk.
But their LSF were completely different.
One patient had an LSF of 9.8%, which is generally considered safe. The other had a very high LSF of 35%, definitely disqualifying them from standard care.
And the CECT method could distinguish between them.
Perfectly. This is exactly why simple volume failed. Remember that low R squared. The CECT analysis showed that the patient with a huge 35% LSF had a tumor that was almost entirely hypervascular, lots of arterial supply, high shunt risk. But the patient with the low 9.8% LSF, even though the tumor was large, the CT method revealed a lot of necrotic dead volume within it, and the calculation method automatically excluded that necrotic part, correctly predicting the lower shunt.
That's compelling. And what about the patients who are actually disqualified from treatment based on the standard MAA scan showing a high LSF? Did the CECT method agree?
Yes, and this is clinically crucial. There were 5 patients in the study disqualified due to high MAA-measured LSF. For those 5 high-risk patients, the CECT estimate was extremely close to the MAA value. The RMSE in that subgroup was even lower, just 2.3%. So bottom line, the CECT-derived LSF calculation would have led to the exact same clinical decision, hold off on treatment due to high risk in every single one of those cases.
Okay, that really drives it home. I think it is almost clear for everyone listening, but give us quick outline of the potential benefits.
We're potentially talking about turning a two-step procedure, sometimes spread over weeks, into a single intervention just by using data from a CT scan that patients often get anyway. One invasive procedure, less potentially freeing anesthesia, less waiting time, maybe getting into effective therapy faster for the patient. It translates into real efficiency gains. You free up angiography suite time, staff, and resources. And you don't need the nuclear medicine logistics. Reduced costs, easier scheduling. There is so much to talk about.
It really could be an efficiency powerhouse, assuming it holds up. To almost conclude, let's talk limitations.
First and foremost, it was a single-center study on a limited number of patients with different tumor entities. Additionally, the authors referred to gamma camera imaging as the gold standard for LSF calculation, which is known to overestimate relative to SPECT CT. Also, probably this method can be applied in patients with a portosystemic shunt, for instance after transjugular stenting, due to the altered blood flow.
Okay, limitations acknowledged. Still, the results are terrific. What needs to happen next?
Well, the obvious next step is validation. Multi-center studies are absolutely crucial to see if these results hold up across different patient populations, different institutions, maybe different CT scanner types and protocols. But I think perhaps even more importantly, future studies need to compare the CECT method not just against MAA, but against the real ground truth for lung dose, which would be post-treatment yttrium-90 PET imaging. After the U90 spheres have been delivered, a PET scan can actually map their location and quantify the radiation dose delivered to the lungs.
That makes perfect sense and is a fantastic outlook for our listeners. This is it, at least for this Radiology Advances podcast. Thanks to Brahim Mehadji and colleagues for publishing with Radiology Advances. If you found this episode informative or have any other feedback, please rate, review, and subscribe. You can read the full article and explore more great content on the journal website. This episode was generated with the help of AI, but all content was reviewed and verified by editor Dr. Luca Salifer from Essen, Germany, for accuracy.